Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Okay, I think we're ready to get started. Hello, everyone, and welcome to this week's edition of Can COVID Speakers Series. Thank you for joining us today. My name is Rosa Stalteri, and I'm the Knowledge Translation Manager for Can COVID and your moderator for today. I have the pleasure of introducing you to this week's speaker, Dr. Stephen Hwang. Dr. Hwang is the director of the MAP Center for Urban Health Solutions at St. Michael's Hospital, also professor at the University of Toronto, and a staff physician at St. Michael's Hospital. Our title for today is the Covenant Study, COVID-19 Cohort Study of People Experiencing Homelessness in Toronto. And just to let you know that we have time for a Q&A session. It'll be about 10 minutes in length. So if you have any questions, please do enter them into the chat box at any point during this session. And so without further ado, welcome, Dr. Hwang.
Hi, everyone, and thanks for that introduction, Rosa. So I'm really happy to be speaking today to just give you an overview of the Covenant study. Just by way of background, I think that everyone is aware that in the COVID-19 pandemic, people living in congregate settings are at greatly increased risk, and particularly people living experiencing homelessness are at high risk of getting COVID and probably also at high risk of adverse outcomes. So during the pandemic, we came up with the idea of doing this study, and thanks to the Canadian Immunity Task Force, the COVID Immunity Task Force and CIHR, this project was funded. I'm going to just tell you a little bit about the objectives of the study and the design of the study and what we've learned so far. So the objectives of the study were fourfold. First and primarily to determine the prevalence of previous COVID-19 infection among people experiencing homelessness in Toronto. To do this over the course of a one-year prospective longitudinal cohort study. To identify risk and protective factors for COVID-19 infection in its population. Thirdly, to build models that will help us to forecast the trajectory of the pandemic in the homeless population. And lastly, and perhaps most importantly, to help inform public health, shelter, and housing interventions to reduce the transmission of COVID-19. So I'm just going to give you a brief overview of the study design. This is an observational cohort study. The original goal was to recruit 700 participants into the cohort, and this is a closed cohort study, so we were going to be recruiting at the time of the beginning of the study only. The planned sites of recruitment are all shelters and shelter hotels, plus large encampments in the city of Toronto, which, as you know, is the city in Canada with, unfortunately, the largest population of people experiencing homelessness in Canada, and to sample a roughly 20% random sample of residents at each of the sites that we were recruiting at. Just by way of background, the most recent estimates of the homeless population in Toronto suggested that in early 2021, there were a total of approximately 7,500 people experiencing homelessness on a single night in Toronto, but obviously more than that over the course of a year. So in terms of our data and sample selection strategy, there are four components to that. We, first of all, recruit individuals, and after they've given informed consent, we perform an interview to obtain information on their sociodemographics, health conditions, their housing history, which is very important, and their COVID symptoms and exposures. We obtain a saliva specimen for PCR testing to detect current infection. and this was selected because it is less invasive and more acceptable than a nasopharyngeal swab and can be performed by research staff who are not clinicians. Thirdly, we obtain a finger prick blood specimen to determine serology to detect past infection. And this is done using a lancet and a microtainer. And if that is not feasible, then we obtain a dried blood spot specimen. And lastly, we obtain permission for database linkages with these participants so that we can link to shelter databases, which help us determine their shelter use and also help us to locate them in the future. And also linkage to ICES, which is Ontario's administrative healthcare database repository, so that we can assess people's healthcare utilization, including COVID vaccinations and COVID testing history. As I mentioned, this is a longitudinal cohort study. So the recruitment is done at baseline, and then follow-up occurs every 3 months for a total of 4 follow-ups over a 12-month follow-up period. So now I'm going to give you some information about what we did in the course of the study and what we found in terms of early results. So I'll just note that this study actually required, there were certain complexities in terms of starting the study. And so we were not able to begin the study until June of 2021, even though we had received funding a number of months prior to that. And I'll speak to that later in the talk. So recruitment of the cohort took place from June 16th to September 9th, 2021 at 61 shelter sites in Toronto. So just by way of context, Toronto has had in 2021 approximately 90 shelter sites that provided accommodation for people experiencing homelessness. And there were also a number of encampments, numbering in the dozens in terms of large sites. We conducted recruitment at 61 shelters and recruited a total of 736 participants, which was slightly more than our targeted total. So we were unfortunately unable to recruit at encampments, and that was because, as you may be aware from following the news, over the summer of 2021, the City of Toronto engaged in a very aggressive encampment clearance strategy, resulting in people at the major encampment sites scattering throughout the city to various more difficult to find locations. And therefore, our original plan to recruit people at the largest encampment sites could not be undertaken. And in addition, there were 28 shelter sites that we approached, but were not able to obtain permission to conduct recruitment at. We were able to obtain serologic data for 99% of the participants in the study. So 3-month follow-up took place during the period September 15th, 2021 to January 23rd, 2022. And we were able to conduct follow-up interviews with 552 participants, which is 75% of the cohort. Now, just bearing in mind that these are individuals who were homeless at baseline, I think that it goes without saying that this was only possible because we were able to utilize methods that we have tested and used extensively in previous longitudinal studies, both observational studies and randomized controlled trials that we've utilized in order to successfully conduct follow-up with research participants who are homeless. So the 75% follow-up at 3 months was approximately what we were aiming for, but certainly required an enormous effort from a highly skilled and experienced research team that was very knowledgeable about how to work with this population. So we're now conducting 6-month follow-ups with our participants. Interviews for the 6-month follow-up, or the second follow-up interview, began in December 2021. And as of a few days ago, we had completed 104 interviews. As you're aware, there are widespread outbreaks of Omicron in the shelters, and that has resulted in closure of the shelters to the studies teams. So they're not willing to have the study teams come in when they're in an outbreak situation. And in addition, a number of community sites where we would normally meet with people in order to do the interviews and the sample collection are also closed. So that's been a significant barrier to conducting follow-up interviews over the last few weeks. So I'm just going to tell you a little bit about the participant characteristics in our cohort, and then some of the initial findings from our early results. So the mean age of our participants was 46, with a range of 16 to 90 years of age. The gender mix was 66% male, 31% female, and 2% non-binary, which roughly mirrors the gender distribution of the homeless population in Toronto. In terms of race, 48% of participants are white, 21% identify as Black, and 19% as other races or identities. 59% of participants were born in Canada, 40% were born outside of Canada, and 28% have a less than high school education, whereas 71% have a high school education or more. So I'm just going to show you, first of all, the PCR results from the saliva testing. So, and I'll show you the results from each wave of the cohort study. So at baseline, which remember was from June to September, we tested 736 participants, and there was only one positive PCR test at the time of testing. I should point out that this is partly influenced by the fact that if someone is symptomatic and in the shelter system, and if they acknowledge that they have symptoms to the people that are at the shelter, they will be, at that time, would be immediately sent for testing and then isolated at the COVID isolation site that we have in Toronto for people experiencing homelessness. So you have to take that into context when looking at these results. At the 3-month follow-up interview from September to January, we interviewed 552 individuals, and there were 2 positive tests, which is a rate of 0.3%. At 6 months, which is ongoing and started in mid-December and is ongoing, we've interviewed 104 participants so far and had 6 positive tests for a positivity rate of 6%, which is notable given that, as I pointed out, people who have symptoms and acknowledge that they're having symptoms would not be eligible for testing in this study because they would have been isolated from within the system, and we would not have had access to them for the research interview. So moving on to self-reported vaccination status at the baseline interview. This has been a topic of great interest in terms of the homeless people experiencing homelessness being a group that we really want to get vaccinated, but who have traditionally had a great deal of distrust in government and in the system, and therefore concerns about resistance or hesitancy about vaccination. So in our cohort, fully 80% of participants had been vaccinated at the time of the baseline interview, which, as you recall, was back in the summer. That 19% were unvaccinated, and less than 1% either declined to answer or said they didn't know. And at that time, the majority of people who said they were vaccinated had received 2 doses. For those who had received 1 dose, we'll be checking to see if they've received that dose subsequently. I should point out that this 80% figure is extraordinarily high. And just by way of context, the City of Toronto asks shelters to report on residents' self-reported vaccination status. And so they track the average number of people who report being vaccinated in the shelter system as a whole. The they reported much lower numbers of approximately 60% during this time frame, suggesting that what is happening is that the individuals who agreed to participate in our study might be those who are more likely to get vaccinated. In terms of self-reported COVID testing at the time of the baseline interview in the summer of 2021, 87% of our participants reported they had been previously tested for COVID. And of those individuals, actually of all the individuals who reported having been tested, 20% reported that they had had a positive COVID test at some point in the past. Now, we looked at our serologic results, and this was done in collaboration with the Gingras lab at Mount Sinai Hospital here in Toronto. And so the serologic status was classified based on the anti-spike, anti-RBD, and anti-nucleocapsid protein IgG levels. And the lab classified their serologic status into these 5 classifications: no antibody response, indeterminate, vaccinated, past infection, may also be vaccinated, or past infection. And I won't go into the details here, but what we did determine is based on the serologic pattern and the individual's self-reported vaccination status and previous infection status, that we determined what we call an adjudicated past infection status, which is essentially our assigned status based on the complete information that we have. And we were able to assess that approximately 30% of our participants had evidence of past infection at the time of the baseline interview in June to September 2021. So just to summarize key lessons that we've learned so far in this study. So first of all, I think it's very clear that for this kind of community research with a disadvantaged population that's difficult to conduct research in using traditional research methods, community partnerships are crucial. And our ability to do this study was really only made possible by relationships that we'd built up in the shelter and homelessness sector in Toronto over many years of doing research of this type with people experiencing homelessness. Secondly, I just want to mention that Indigenous community organization partnership and data ownership is essential. And this is something that I did not fully recognize and understand at the outset of the study. And it was in recognition of the fact that approximately 15% of people experiencing homelessness in Toronto are Indigenous, that there needed to be an Indigenous community organization that was a full partner and had co-ownership of the Indigenous participants' data. And I just want to acknowledge and thank Anishinaabe Health Toronto, which is the community organization that is partnering with us on this study. Thirdly, as I've already mentioned, in order to do this kind of a cohort study, experience in the recruitment and follow-up with people experiencing homelessness is essential. And we were able to do this because our center has a survey research unit that is highly experienced and skilled in conducting survey research with difficult to reach populations, and that experience was essential. Fourthly, I just want to point out that rapidly developing events in our urban environment affecting the homeless population can rapidly outstrip the pace of research. And I've mentioned a few of those. For example, the fact that encampment clearance efforts resulted in difficulty reaching that group of the subgroup of the homeless population. And certainly with the current Omicron outbreak, what we've experienced is that this is a significant factor that we've had to adapt to in conducting this research study. And it may result in some delays in follow-up, which will then, I think we may end up, rather than catching people during the Omicron wave, we may end up following up with people afterwards and seeing the extent to which Omicron has affected people over the last few months. And so I just want to, with this slide, thank the large group of co-investigators and collaborators who have made this research, without whom this research would not be possible. There are too many to name individually, but I just want to say that this is completely a team effort. I want to thank our funders and partners, and in particular, as I mentioned, the COVID-19 Immunity Task Force and CIHR who funded this project, our collaborators at Mount Sinai Hospital and the University of Toronto, and in particular, Anishinaabe Health Toronto for being a partner in this work, and then the City of Toronto, Toronto Public Health, the Toronto Shelter Network, and the Canadian Alliance to End Homelessness. Thank you very much.
Thank you so much. Seems like a really big and great team that you have there. And thank you so much for the presentation. It was very interesting, and we're going to get straight into the questions. So the first one we have here is recruiting more than 700 participants over a short period of time is fabulous. How did you manage to have a high success rate in the recruitment phase?
So that's a great question. So as I mentioned, me and my team have been doing work in this sector. We've been doing research in this sector for more than 20 years. So we're not newcomers on the scene. We have I guess, a track record and a reputation of working collaboratively with the sector. Certainly having the City of Toronto and Toronto Public Health as partners was critical. We did a lot of speaking with the sector and engaging with them, and doing a lot of one-on-one meetings as well. And it really comes down to a ground game of having our survey teams going out to the shelters and working with the staff at the shelters, and reaching out to people and approaching them on a random selection basis to see if they're willing to participate. I should also mention that we do pay a cash honorarium to participants at recruitment and at each follow-up, which is important in terms of retention.
Thank you. And the next one is, can you expand a bit more on the methods utilized to reach at baseline and during follow-up people experiencing homelessness who are considered as hard to reach populations?
So in terms of recruitment at baseline, as I mentioned, was primarily based on going out to shelter sites. In terms of follow-up, we have developed we've done randomized trials in this area. And so our survey research unit has methods such as asking people for not just their phone number if they have one, but what places they go to, what drop-ins or other service sites they tend to hang out at, whether or not they have friends or relatives who we might be able to reach out to in order to contact them for follow-up. And another thing that we do is we actually offer the opportunity for people to call us at a toll-free number during the month before their next follow-up interview to just check in with us and let us know where we might be able to reach them. And we offer a financial incentive and an additional honorarium if they check in with us in advance of the follow-up time point.
So one of the questions that I got privately was in regards to whether the interviews were done in person or via some technology. So I'm guessing this was done via in-person interviews.
Yeah, so each interview requires collection of a saliva specimen and a blood specimen, so they were all done in person.
So the next question here is, how can members of the public help support the homeless population, especially during periods of extreme winter weather, given challenges the pandemic has presented?
So this is a huge question that we're grappling with in Toronto, and I know many cities are grappling with this. I guess there are two levels. I guess first of all is, you can give to, nonprofit organizations that are working hard in our communities year after year and winter after winter to serve people experiencing homelessness. I think secondly, and probably equally importantly, we can push our civic leaders and our city governments to do a better job of opening adequate space for people so they're not exposed to the elements. And lastly, I guess that, we have to look at the long game here, which is ultimately the answer is not providing more shelter beds. The answer is creating more housing and supports for people.
So the next one we have here is, have you had a chance to explore vaccination status at baseline and during follow-up period? Have you attempted to assess vaccine acceptance or change in attitudes towards vaccination among this population?
So yes, we're hoping to do that. We're going to do that. As you see, we just completed our 3-month wave, our first 3-month follow-up wave just within the last few days. So we are going to compare and look at the uptake of vaccination over the last 3 months. We're also recognizing that vaccine attitudes towards vaccination is important to assess in a qualitative. We're doing a qualitative sub-study, which is being led by my postdoctoral fellow, Jesse Jenkinson, looking at attitudes towards vaccination and why people might be hesitant. So we hope that that will provide useful information to try to encourage higher vaccination rates.
The next question we have here is, what do you think the City of Toronto could have done differently to prepare for winter to help support shelters and the homeless population, particularly as we're seeing many COVID-19 outbreaks in shelters?
Yeah, that's a great question. I mean, I think that COVID outbreaks was going to happen in any shelter. Like, I don't think that with Omicron, I don't see how any shelter could avoid an outbreak. I think that what we are seeing is that there's not enough shelter beds available for relative to the need for beds. And we're seeing that in our hospital, where people are in the emergency department, they have no place to go. They're homeless and they have no place to go. So, I think that just allocating adequate resources to ensure there are enough beds for people is important. But I guess that, as I mentioned, it's a paradox that, yes, we need to use more resources to have enough shelter beds, but if you do that, if you focus on that as a solution, then you can spend all your resources opening shelters and not addressing the problem of homelessness. So, but I think certainly we don't have enough shelter beds, and that's probably true in many cities, I think.
The next one is, and I'll just summarize. In your data, you had reported on race, and one of the categories was other. Someone's just asking if you can tell more about what the other was.
Yeah, actually, we asked people to self-identify, and we have much more complete information on self-identified race. However, I didn't want to report it for the purposes of this this presentation. And the other consideration is that for people who self-identify as Indigenous, any analysis and reporting of that data needs to be done in partnership with our Indigenous research partner. So we're not presenting that data at this time.
And the next question here is, can you expand more about how you use self-reported vaccination status with the serological results to determine that 70% had no past infection?
Yeah, so that's really complicated, but in brief, we use the serologic data to identify people who absolutely, with 100% certainty, have had past infection. And then there are additional group of people who have a serologic pattern that it suggests either vaccination or past infection. And for those individuals, we use their self-reported vaccination and infection status to help sort out whether they've been vaccinated or had past infection or both.
Sounds very complicated. The next question we have here is, how did your team reconcile tension between actions taken to clear encampments, and partnerships with the city administration in conducting research? Is there a challenge?
That is a great question. I mean, I think that our partnership for the research is I think separate from our position on, it doesn't mean that we agree with everything the city does, and it doesn't mean we disagree with everything the city does, but it does mean that we do have to, I would just acknowledge that there are tensions in those kinds of, when you have a partnership with many different agencies, and some of which have different perspectives on what should be done. It does raise the question of, how do you engage? Certainly, I felt that the encampment clearances was clearly the wrong thing to do, and we a number of us kind of spoke out about that, and but it can be difficult.
Okay, and then a final one here, because we're just at time, is, were the characteristics of the shelters that were not included different from those that were?
That's a great question. I don't have that data, and I should definitely, that's a good reminder to me that we should prepare that information. We would obviously only be able to report on things like which population that they served. I think we got a pretty good cross-sectional representation of each sector, so I don't think that it was like any one sector was missed out, but I don't have that data, and I will have it ready for the next time I present this study.
That would be great, thanks. Yeah, maybe we'll invite you again for another one to present that. But I do want to close here, and just to say, on behalf of the CAN COVID team, I'd like to extend our sincere thanks to you, Dr. Hwang, for sharing with us the impact of COVID-19 transmission on people who are experiencing homelessness in Toronto. And I just want to note that please join us for the next speaker series, which is on February 1st at 3 p.m., where we will hear from Dr. Pang and Dr. Parkins on COVID-19 modeling from Alberta's wastewater program. So that concludes today's event. Thank you again for joining us, and we'll see you at the next one.
Bye. Thank you, everyone.
Thanks.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CAN COVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.